Good afternoon, everyone. Welcome. Welcome, everyone, faculty, prospective students, and guests. I'm very happy to be here today to talk with you about a topic that I'm most passionate about, patient safety and patient-centered care as reflected by the patient experience. And I'm Dr. Sherry Hill. I'm an clinical assistant professor with the Department of Medical Education in the Patient Safety Leadership Program. So I hope you enjoy today's presentation. Next slide, please. So there's three learning objectives that I want to highlight today. We'll be talking about the evidence that exists about the relationship between perceptions of care or patient experience and patient safety. We'll also really look at the impact of the patient's perception on their experience of patient safety. And lastly, I want to talk about the significant features of a patient and family advisory council and how this connects patient experience and patient safety. But primarily, I really hope to, in this short time, really prompt your curiosity and your desire to learn more about patient safety and patient experience. And I'll go through this presentation in about 20 minutes. I'll take questions at the end, and you can enter your questions in the question box within the webinar. Next slide, please. So by way of background, I'd like to talk with you about the larger context within which patient safety and patient experience is embedded. And that, as you know, is the really complex and rapidly changing healthcare environment that we're all a part of, either as providers or patients, if not patients now, patients in the future. Next slide, please. Within the background of all of this, as a backdrop, really is the triple aim, or what we're going to refer to as a quadruple aim. The triple aim was something that you're probably already familiar with. It was introduced in 2008 by Don Berwick and his colleagues through the IHI Institute for Healthcare Improvement as an approach to optimize health system performance. So healthcare leaders are very familiar with the triple aim, and the triple aim proposed that healthcare institutions should simultaneously pursue three dimensions of performance. And starting with the upper right of the diagram, improving patient outcomes, enhancing the patient experience of care, and reducing the cost of healthcare. But more recently, in 2014, an article was published in the Annals of Family Medicine that addressed burnout among healthcare workers and the healthcare workforce as a whole, and that this is a big threat to patient-centeredness and really being able to achieve the triple aim. The authors discussed that the triple aims were necessary to exceed in the new era of healthcare, but there's a key component missing from this equation, and that's healthcare providers themselves. And without a focus on staff, achieving the triple aim goals would become a challenge or maybe even impossible. So incorporating a fourth aim is the belief that organizations who take better care of their people will develop a competitive advantage in that happier, healthier providers deliver higher quality and safer care with a better patient experience. And this is what you'll see discussed in the more recent years, the quadruple aim. Next slide, please. And I also want to take a moment to level set about what I mean when I say patient experience. And there are several definitions of patient experience in the literature, and it's often used interchangeably with patient satisfaction. But for the purposes of my presentation today, I really like the Barrel Institute definition. And the Barrel Institute is an independent, non-vendor or provider-related, non-vendor and non-provider related organization that really focuses on strictly improving the patient experience. There's 40,000 members in over 50 countries, and the website contains many interesting white papers and resources for those seeking to improve the patient experience. So the definition is coming from a patient-centered concept, and the Barrel Institute believes that a patient experience is the sum of all interactions shaped by an organization's culture that influence patients' perceptions across the continuum of care. So essentially, they're saying everything is the patient experience, everything from the moment the patient picks up the phone to make a doctor's appointment to a complicated discharge plan. So it really is a very broad and encompassing context to consider. Next slide, please. So why is patient experience important? Again, just to level set as part of the background. There's one thing that comes to mind, especially among healthcare leaders immediately. Why is patient experience important? Well, basically because of many Medicare payment reduction programs. Most specifically is the first, value-based purchasing. Value-based purchasing includes four domains: safety, clinical care, efficiency and cost reduction, and lastly, patient experience. So under value-based purchasing, patient experience is measured by HCAHPS, which is an abbreviation for Hospital Consumer Assessment of Healthcare Providers and Systems. It's a survey that's really sent to patients who've been in the healthcare system. But based on those survey results, there can be a 2% reduction to hospitals under value-based purchasing. And that really has been, over the last several years, a factor that leaders have had to consider. And then under quality, under patient safety, there is the Hospital Acquired Condition, or HAC program. It's also a Medicare payment reduction program. And under this program, a hospital can lose up to 1% of a reduction based on their performance in certain quality and safety indicators, such as central line infections, catheter-associated urinary tract infections, surgical site infections, and several others. So these multiple payment reduction programs actually result in a huge reduction, up to millions of dollars for organizations, because it's applied across all Medicare discharges throughout a federal fiscal year. So healthcare providers are, very focused on these Medicare payment reduction programs. In addition, they realize that we must deliver healthcare that meets demands for both patient experience and patient safety, just to meet the basic needs of our patients. It's all encompassing, all incorporated. And to do this, we have to simultaneously be responsible to individual patient needs as well as delivering patient-centered care. Next slide, please. So all of this is really basically saying this is a huge challenge. Patient safety outcomes, for example, even something as simple as hand hygiene compliance, require high levels of accountability and adherence to evidence-based practice. Whereas patient experience outcomes require care providers to really center their care delivery processes around patient needs and preferences. So it's two different things. Clinicians define safety differently from patients. Clinicians often focus on outcomes, whereas patients may focus more on processes as they decide what is safe or not safe. And really, the question that we ask now is, how can patients have a good experience if they don't feel safe? Next slide, please. So what do we already know? I would like to just highlight 5 studies that you might find interesting from the growing body of literature examining the relationship between patient experience and patient safety outcomes. I really just want to encourage you to read these and others as they're being published, and hopefully this will get your interest. Next slide, please. So the first is a 2011 qualitative study of 996 patients that examined patient safety from the patient's perspective. This is important because it was one of the first and one of the few to look at things from the patient's perspective. And in this study, it was found that patient safety mediates the relationship between quality and satisfaction. And as patients become more satisfied with service quality, they reported more positive experiences with patient safety activities and procedures. What also is really interesting about this study is the second bullet, that patients who reported service quality problems perceived risks to their own safety. So what I mean by that, an example of this is a patient coming into a patient room that maybe is not clean, or they see garbage on the floor, or a used 4x4 gauze pad on the floor, and they'll see that and make the leap that, my goodness, if they don't care about this garbage, or they don't care about the way this environment looks, how can they possibly care about my safety? So they make a big leap from one thing to a perceived risk to their own safety. So again, it reminds us how important the perception and understanding of safety is from the patient's perspective, really. There are implications for our practitioners really to pay attention to how these processes impact patients and how they infer safety when they're in our hands. So next slide, please. The second is a 2013 systematic review of 55 studies, and this was significant across a range of disease areas, study designs, settings, population groups, and outcome measures. And the review showed an overall positive relationship with various patient experience and patient safety outcomes. The study supported the argument that patient experience and clinical effectiveness and patient safety are linked and should be looked at together as a group. Notably, the authors in their discussion of their study really give us a call to action. And they say there that leaders, clinicians, really leaders, should resist sidelining patient experience as being too subjective or mood oriented or divorced from the real clinical work of measuring safety, and that we should pay great attention to this, and that in the future, patient experience will become more and more important, which has proven to be true. So next slide, please. This third study from 2016 was interesting in that it sought to test the associations between the Centers for Medicare and Medicaid CMS patient experience star rating, which you may know is publicly reported information, and clinical outcomes. So a risk-adjusted analysis of more than 3,000 US hospitals demonstrated a positive and significant relationship between patient experience measures and favorable clinical outcomes. Many favorable clinical outcomes, including lower rates of hospital-acquired conditions, mortality, length of stay, adherence to treatment protocols post-discharge. This was quite interesting, and also that a better patient experience was associated with lower rates of unplanned readmissions to a hospital within 30 days. So all of these things are of great interest to healthcare leaders. And the results of this study basically support payers including patient experience data in the framework of their payment methodology to healthcare organizations. So very interesting study. Next slide, please. The fourth study that I'll mention is sought to really better understand the relationship between nurse-reported safety culture and the patient experience in this multi-state sample of nurses and patients. So the key variables, HCAHPS is, as you recall, it's the measure of patient experience, and the HRQ survey is the measure of patient safety culture. And this study reported that there were significant correlations between three safety culture domains and a positive patient experience. And those three were teamwork, staffing, and organizational learning. So there are implications there for practitioners who are interested in both improving their safety culture and improving their patient experience. And the last study is from 2017. And this study was looking at managers and clinicians and how they perceived the patient safety culture or climate, and found that patient satisfaction was significantly higher if managers and clinicians reported that the patient safety climate was high. So there was a high level of communication openness, feedback, and communication about errors, teamwork across units, and these were positively and significantly associated with patient satisfaction, especially in the areas of discharge information and communication about medications. So next slide, please. Next slide. So I'm sorry, next slide. So summarizing these studies, as we know, associations really do not necessarily entail causality, but the studies do show that improvements in patient experience might cause or may cause improvements in patient safety, that it's reasonable to hypothesize that steps taken to improve patient safety may ultimately result in improvements in patient experience. Safety and experience are most likely linked, as both are manifestations of an underlying hospital culture of safety. Here, I just want to mention that, we're all really focusing on improving safety culture, and looking at these things separately probably is not going to get us to where we want to be. Importantly, there is additional research that is required to understand how patients decide whether they are safe and if they are satisfied, and that's really lacking in the literature. So next slide, please. So now I'd just like to talk about a study that's currently in progress in 2 hospitals in the Chicago area. And we know that the concept of patient experience is related to a patient's direct and indirect experiences within the healthcare system and interaction with healthcare providers. So this study really sought to provide information to leaders to better understand a patient experience. Next slide, please. So the leaders in these two hospitals really started out with a few thoughts in mind, a few basic ground rules. And that's going back to the definition that patient perception of patient safety is important and patient experience is everything. We also know that leaders are encouraging patients and families to take a really proactive approach in ensuring patient safety. So therefore, patients need to understand, we need to understand how patients define their own patient safety. These perceptions could influence outcomes such as trust and satisfaction. And most importantly, the leaders felt a lack of really understanding about patient perspective, and this could be an additional lens for viewing complex systems and processes for quality improvement efforts. Next slide, please. So an approach was selected, ethnography, to really understand the patient experience better. And as a reminder, ethnography really is the study of interactions, behaviors, and perceptions. The aim of this type of study is to really obtain a rich and holistic insight into people's perceptions about an experience through the collected detailed observations and interviews. And we hope to really get inside the way a group of people see the world, or in this case, see their experience. Next slide, please. The method was observation and interview of 63 patients in this hospital, in these two hospitals, between August 15th, 2017 through June 30th, 2018. And aspects of the patient experience were obtained through observation and focused interview. The entire patient experience was assessed during this time frame and included perspectives from patients and family members. And then the idea was to identify themes related to people, processes, and cultural issues that might lead to dissatisfaction. So by way of demographics, 64% of these patients were male, 36% were female. The age range was 34 to 90 years old, and they were all cardiovascular patients participated in this particular study. The interactions took place in the hospital, in physician offices, in ambulatory locations, and it also included experiences with MyChart or the electronic medical record, other reports that were or documents that were given to patients. And interactions also encompassed physicians, nursing staff, office and administrative staff, technicians, therapists, and even the greeters at the door of the hospital who was the first person that a patient might see. Next slide, please. So results. Our preliminary results give us an idea of what patients want with regards to safety and patient experience. In our study, 84% of the interactions were associated with positive emotions. Patients perceived a safe experience if these 4 areas were addressed, and if they perceived these 4 areas as being addressed. The first is responsiveness from staff. If they needed help or called for help or asked a question, they felt that there was a degree of responsiveness, that they weren't dismissed, that people were paying attention. And along with that was clear communication, that they received information that they could understand and they could share with their family and understand even post-discharge from the care setting. The 4th bullet was really very interesting to us. Demonstrations of patient-centered knowledge was seen as very important. And what they meant by that was if a care provider knew something personal about the patient, for example, the name of the wife or the name of the children or grandchildren or where they lived or what they did for a living, this was seen as patient-centered knowledge to them, and it really helped make a personal connection with the providers. So this is really kind of soft stuff, but it's all about developing relationships. And this is what they're asking for. And this is how they made a connection to having these things resulted in a positive emotion and a positive feeling about patient safety. And next slide, please. And then, of course, there were those who had concerns with their own safety. And these were basically relating to 5 themes, all process oriented. The first is patients desire emotional support. They're looking for relief from fear and anxiety. They're looking for um, actually a bit of psychological support and reassurance. And where they could have that, they felt, again, safer in the environment. They also are looking for respect and understanding, and this has come out in the literature as well, that they're wanting to be seen as individuals. They want their beliefs, values, and concerns to be respected and understood, and that these things are also consistent with patient-centered care. Interestingly, they also wanted to be sure that their family and or caregivers were involved in discussions, and that we recognize and acknowledge those family and caregivers. An example was given um, where a patient was, in bed bound, and the husband was sitting vigil at the bedside day after day, night after night, and the caregivers would walk into the room and talk with the patient in the bed, but completely ignore the husband. And after a while, this was really seen as just really not making any efforts to involve or support the family and the caregivers. So this was a desire that came out and would also contribute to patient safety. When they know that patients know that things do go wrong, and they want to be assured that the organization is transparent, honest, and would disclose when something does go wrong. So this was seen as another kind of trust issue, that if they could trust that we would tell them, then they felt safer. And finally, participation in decisions. Very, very common theme. People want to be involved, and that makes them feel safer and perhaps in control as well. Next slide, please. So this organization currently is in progress with now taking this information and translating these opportunities from the current state into a desired state. And this is a kind of a graphic that shows the process that's being used. The idea is to list out, the things that are in the current state that need a transformational change. So not to fix the problem, but to really identify first a desired state, a new way of doing the work that needs to be done, and a way of improving then safety and patient experience. So for example, the current state, we know that there was a lack of patient and family involvement in decisions. And one way to address this would be in a desired state to create structures that could better involve patients. Next slide, please. One way to do this that is fairly effective, has been fairly effective, is through a Patient and Family Advisory Council, or PFAC, it's known as. And a Patient and Family Advisory Council really is a voluntary group, generally patients of a healthcare system who come together. Sometimes these are patients who've called to complain and are invited to be members then of the advisory council. And these people serve as an advisory resource to leadership and staff, and can provide a vehicle for communicating back and forth between patients, families, leaders, and staff. It's also an opportunity for patients to review ideas and recommendations from their perspective. And I'll give you an example from this organization. The organization had planned a campaign, and they were calling the campaign Road to Zero Harm campaign. And the idea was part of their high reliability initiatives, and posters and banners were created, and these were going to be placed in the front lobbies of the hospital, that we are on the road to zero harm. And when the organizational leaders took this to their Patient and Family Advisory Council, there was a very negative reaction from those members. They said that actually seeing that we're on the road to zero harm made them more fearful, that they felt we should be at zero harm, or that we definitely, who knows what's happening. They felt very insecure about that. And one patient said it's like going to the airport and seeing a sign in the airport that says we're on the road to 0 plane crashes. There's just things that are assumed, and so they didn't want to see any of these things in public areas. And so actually the organization used all of that. All of those banners and posters in off stage locations, and so they're only visible to staff to see, as this was a new perspective that hadn't really been considered until it was reviewed by the Patient and Family Advisory Council. So it really is a formal way for patients to be involved in decision making, and can be extremely powerful. Next slide. So coming from this group of patients, as they talk about, as they've begun to talk about the ethnography study, is that they believe that patient safety should not be a covert intention. It should not be subtle or hidden. It should be out there what we are doing. So, for example, if we're washing hands, that caregivers are explaining, I'm washing hands for your safety. And they're basically looking for those connections, and they feel it should be first and foremost, and spoken about. They wish that patient care providers would tell them about risks like fall hazards and tripping hazards, or hand hygiene, and tell them that these things are being shared to help them have a safer experience. They also wish that we would ask family members to partner in keeping patients safe and talk to them as caregivers perform hand hygiene and other things that they're doing in the room. They really want us to be open, obvious, and repetitive in demonstrating our ongoing concern about the welfare of patients. They don't, all of them come in with the feeling of trust. They want to be reassured, and they want to feel as if we are making the connection for them and watching out for their patient safety. This is what's going to help them have a better experience. And most of all, we hopefully never say something like we're checking your identification because Joint Commission or someone tells us we have to. It's Safety really is not a regulation. It's an ethic of practice, and so really implies a culture change, and that's what uh, patients and family members are really looking for. Next slide, please. So we have a timeline here in this organization to kind of where are we going with all this information. So just to kind of take you on this journey, because it's not a static, anytime that we're looking, especially at ethnography information, it can be sliced and diced in so many different ways. And so really in 2017, this organization created a Patient and Family Advisory Council that then kind of initiated the ethnography in August of 2017. The ethnography went through June of 2018, as I mentioned. And so now we're really looking here at the results for analysis, and plan in December to take the entire report to the Patient and Family Advisory Council to really get their feedback and opinions about what it is that we're learning. And then starting in January of 19, we will begin improvement priorities and action planning and improvements. And I think the take-home message here is that these improvements are driven by the voice of the patient, and that they're patient-centered. And these are things that really, if we keep bringing ourselves back to what is the best for the patient, that's the guiding aim with all of this information. Next slide, please. So in conclusion, there really is much to appreciate from this very brief glimpse at some of the knowledge about this dynamic relationship between patient safety and patient experience. And we know, from the literature, that there is some relationship between patient experiences and interactions with healthcare providers. We also understand that patients' own experiences may not directly relate to the actual care or quality that was provided, but it's rather their expectations of what they believe should be provided. So it's quite different. And perception is everything. So we keep going back to that. We do feel that patients, families, and providers are in this collectively and collaboratively, and we want to better understand those dynamics and how they come together to really create a great patient experience and superior patient safety and zero harm. And lastly, there really is, when all is said and done, very much that is still unknown, and we must continue to explore this dynamic in much greater detail. And hopefully, more research is being done in these areas. Next slide, please. So this just, as I mentioned, I had a few references that, next slide, please, that I'll share. I would suggest that these are just representative of some of the studies out there, but it's very interesting when you start to look at things in different ways from the patient experience and from the patient perspective, and how do they interpret what we do in terms of our patient safety initiatives. Next slide, please. So I'd like to just talk a little bit for a couple of minutes about my role as an instructor in the Patient Safety Leadership Program at UIC. And as an instructor, I do work very closely with students on developing their capstone projects. I also generally meet most of the students during their on-site residency program in Chicago, which is really one of the highlights, I think, of the program, to come together and meet their colleagues and really work on their capstone program. Capstone project. You can learn more for the students, actually. You can learn more about the topic that I covered today in the Patient Safety Leadership Program. This and many other relevant and emerging safety topics are covered in the course content. And if you are a prospective student or interested in the program, my topic today may give you some ideas about a capstone opportunity. I really hope that people see this as a very interesting area to investigate. Next slide, please. And lastly, here you'll see the two options that are available, the Master of Patient Safety Leadership Program and also the Patient Safety Leadership Graduate Certificate Program. And all of the particulars are listed there. And next slide, please. If you have any questions about the program, you can inquire using the web or the email address there, onlineinfo@uic.edu. And this will conclude my formal presentation. And now I would like to take any questions from the audience. So, and Sean, you might want to double check this for me. I'm not seeing any questions in the chat box.
Yeah, so everyone, you can go ahead and type in any questions that you have and there's our first one. Sometimes it takes a little time for that to show up.
There, I know, I was just seeing that too. Okay, so the question is, can the certificate program count towards credits for the graduate program? And I believe the answer to that question is yes. People sometimes start in the certificate program and just love it so much that they continue on in the graduate program. Great question. Any other questions?
And just so everybody knows, the questions can be about the the presentation itself or the program, so feel free. There looks like we have another one.
I'm not seeing that. Oh, here. How willing were the staff to participate in the ethnographic study? So this is interesting. Let me talk first about the patients. So the way we got or were able to recruit participants, attending physicians, or actually in this case, attending physicians and cardiologists invited their patients to participate and gave a letter of invitation, so that they were the initial point of contact, inviting their patients to participate. And then the staff who were actually involved, staff groups such as case managers, social workers, nurses, different focus groups of staff were involved in the study as well, and just invited to come, and they were very willing to express their feelings and thoughts about patient safety and patient experience. And we did actually process flow out different things like how do patients register and how do patients get their post-discharge phone call, to better understand the work processes as well. So it was interesting that so many people were very excited and willing to participate both on the patient front and staff front. And actually, it didn't, it was time consuming for people who were collecting the data. We had three people three individuals who were involved in the interviews and transcribing data and transcribing this information and really conducting the study. And they were very excited because it was seen as very meaningful and important information that they were gaining for us. Great question. Can we obtain a transcript of this presentation? I think.
Yes, Sandra, we are going to send out a recording of the presentation.
Can you give examples of student capstone projects? Oh my goodness. There's so many fabulous projects that people are doing. We have some people who are looking at, specific things like second victim programs and implementing training protocols for pharmacy residents to reduce potential medical errors. And it's really what happens often is people come with their own area of passion and interest, and we can help then help them visualize and create a capstone project that really meets their needs. So it's things that they're really super passionate about. So I've seen many different kinds of capstones. You can people do projects, people evaluate projects that have already been implemented, and they can even do kind of a scoping literature review to see what's in the literature and really do that. So most of the students are coming with ideas in mind even when they first start the program, and throughout the program I'm touching bases from the very beginning with people to help them get that into good shape so that it becomes a project. So the sky's the limit for sure. I'm seeing, I hope I'm not missing, how do you build support among leadership for an in-house study like this? So interestingly, somebody has to kind of be the voice. Anybody can be the voice that calls out, let's understand the patient experience better. And in this case, there was a patient experience manager who felt that there just wasn't a direction. All this organization was doing was putting out fires and addressing complaints, and wanted to get to a different place with that. So basically showing the leaders kind of the evidence from the literature and showing how we really don't know where we're going and we don't have enough information to get to a better place. And in this organization, the leaders were very, very concerned about doing a better job at patient experience. They were also concerned about patient experience and safety being a differentiator. We're in a really competitive market here in the western suburbs of Chicago. There are many hospitals, and the idea was this really can distinguish an organization strong safety programs, great patient experience, high quality, those things all go together. And we found it very easy to have leaders get on board with that, especially when we started showing them the ethnography study. We teach implementation planning, evaluation planning, integrative reviews as capstones. That's an answer to the previous question about types of capstones. Sean, I'm not sure if I'm missing some questions here.
It looks like what is a capstone or project required for the certification program? Which the answer to that one is the capstone is actually part of the full master. So if you do the certificate program, you would not be doing the capstone, but if you move on for the masters, then you would. Does program curriculum contain a program management aspect? Is another question here.
You mean like a project management? I'm not sure if you're meaning a project management plan.
And maybe Dorothy, maybe you could give us a little more clarification there. Then it looks like can you give us some examples of career paths with this degree in both private and public sector?
Okay, great. Great. Well, I can address that. I think it's interesting because I see so many applications. Just as a hospital administrator, I can see how this degree would benefit people in so many areas. So any kind of clinical area, if you're a nurse, physical therapist, a pharmacist, we've got physicians, all of these things can help them become leaders in take more of a leadership role in their areas. So if they're already looking at advancing in their role, even as a nurse, I've had people with this background coming into quality departments, coming into patient experience departments, coming into infection control, because patient safety is it's such a hot topic now. So I think it really, there are jobs also out there, patient safety leaders, patient safety officers, patient safety managers. You're going to see those types of jobs out there. Even on the internet, if you do kind of a career search, you're going to see those types of things. And this information, what you gain from this program, as I said, can be applied no matter what you're doing. I've got people in billing and registration that or risk management that find value in just understanding the basic concepts, because you can apply patient safety knowledge in so many different venues, in so many different levels of care: hospital, ambulatory clinics, physician offices, even in community centers. So I think it's one of the best degrees out there to get for anybody interested in a healthcare leadership role. So there's a question about how do you start a patient and family advisory council in a local hospital? So basically, you're looking for volunteers. So oftentimes you have perhaps someone who deals with complaints in an organization, and we connected with those people to start inviting people to be part of this program. Would you like to be on advisory council? If someone wants to email me, I can provide much more information. The Illinois Hospital Association also has a very robust website, how to start a patient and family advisory council. It's one of their key initiatives. So, it addresses everything from, recruitment to how do you set the first meeting, and what kind of issues do you bring. So you can look at the IHA website, Patient and Family Advisory Council, or email me and I'll give you the particulars. But in the end, you want to end up with about 20 to 25 people. They really like to have dinner, so most organizations provide a meal. Most of them are, a lot of them are working professionals, so they come, they're more likely to come if you do a 5 o'clock meeting. So there are many different ways to do it, but I'm a big believer in the value of the information that can be gained. Okay, what else? Anything else? Oh, does someone, there's a question about health information technology. And I will mention that that's a component of, definitely a component of the course content, very important component, and a huge area for that would, anybody in HIT, I think, would benefit from from this program, definitely. In fact, there is somebody doing a capstone right now on HIT implementation and the problems and the barriers. Okay, so I can't, my little
Oh, there
box
was.
for questions
Yeah, I can read them to you.
is an
Um,
opening.
yeah, it's Dorothy gave a little more clarification. I found making changes. So this was about sort of program management, requires skills in program management in addition to patient safety knowledge. So does UIC incorporate lean or PMI processes? I'm assuming into the
Oh,
program. Yeah.
so I don't, there is a, oh, you know what? I think if she could just send that question in as an email so I can answer most appropriately. I do believe that there is some project management,
Yep.
basic project management content.
There is, and I believe there's also an elective that occurs in summer one. But
Yeah,
yeah, Dorothy, if you want to send an email just so we can more thoroughly address that question, that would be great to the online info at uic.edu.
yeah, I think you're right. I think it's a elective in quality maybe that has that content.
Perfect. And then look like one more. Is the Illinois residency required to obtain what the tuition is? No, Patricia, the tuition is the same. It's online. So it's the same as if you're in state or out of state or even international. It's all the same tuition rate.
Great. Any other questions? Did we get them all?
I think so. If we missed any, please do feel free to email those to onlineinfo@uic.edu and we can address those to everyone.
Well, we will conclude today. At this point, I'd like to just thank you all again for attending and listening to this topic, and feel free, as Sean said, to email any questions. And it's been a pleasure being with you today. Have a great rest of the week.